So we've talked a lot today about joy in practice, and we really wanted to come back to the idea of what does all of this have to do with the patient-centered medical home, something we spend a lot of our time thinking and talking about. So we want to approach that conceptually, and then we also want to approach it thinking about the innovations and how they fit in. Conceptually, we ask the question, what do patient-centered care and joy in practice look like without each other? So we could imagine, first of all, a practice without patient-centered care, without joy in practice, and we have what now is too often the current state of affairs. We have the burnt-out physician, the frustrated patient, and low quality indicators. But what would happen if we were to pursue patient-centered care without thinking, without a mind to joy in practice? Well, we would probably pursue a lot of the things that we think about with patient-centered care. We would try to have population-based management. We might do a lot more data-driven improvement. We might have our EMRs, and we'd be trying to feed those quality metrics back to the physician. And too often that comes as additional burden piled onto the clinician's plates. Trying to build a patient-centered medical home without considering joy in practice doesn't work. And we look at the group health experience of the early 2000s, where they were trying to push for increased access, increased quality. They were trying to reduce cost and increase their patient-centeredness. Their physician burnout hit the roof. Their quality metrics dropped and their cost increased, and particularly those downstream costs of hospitalization and emergency department use. Now, conversely, what would it look like to pursue joy in practice without patient-centered care? Well, if I were embarking on that kind of a venture, I would try to find the most expedient way possible to make my clinicians a little bit happier. Perhaps I would have an employee of the month. Perhaps I would increase their pay a little bit, none of which are necessarily bad things. But considered without the patient, they don't really drive at joy in practice. If, in fact, joy in practice is really predicated on a relationship between staff and with patients, and if people are entering primary care because they want to have a long-term healing relationship with their patients, then simply tweaking things to try to drive up a little bit more satisfaction is not really the answer. In fact, when I showed this slide to Chris, her first reaction was, how can I possibly be happy if I have a room full of frustrated patients? And I think that's a sentiment that would be echoed by a lot of primary care practitioners as well. So we can't really pursue joy in practice without a mind to patient-centered care. Finally, what do patient-centered care and joy in practice look like together? Based on our experience at these 22 sites, we think they look like teams, like well-developed, well-trained teams that are in close collaboration with each other on a minute-to-minute level and are working toward patient-centered care. Joy in practice in the context of patient-centered care requires that the team accepts the culture shift from I to we that we talk about a lot. And that's really a culture shift that has to happen with clinicians, also with the staff that they work with, and also within the organizations, so that those organizations are working to remove the barriers that are preventing us from truly and effectively sharing the care. It also means that responsibilities and not just tasks are shared systematically and thoughtfully. There's a big difference in practice when you see practices that are sharing tasks and those that are sharing responsibilities. Sharing tasks are things like fax this form or fill out this document. Sharing responsibilities is going to clinical support staff and saying, you are the people who can best help make sure your patients and our patients get their colon cancer screening. We can give you some tools to do that, but we need your help in figuring out how to make it work. That's a very different kind of interaction. That requires that workflows and standing orders and training really empower the team to share the responsibility for the health of their patients. And that means training not only for the clinical support staff, but also for supervisors who are going to have to pay attention to different things that clinical support staff is doing. And it's also training for clinicians who are going to be interacting with their teams in a very different way than before. Finally, it requires that practices invest in their teams. That means as new funds are used for hiring and training come into the practice, they're used to try to reach those ratios of 2 or 3 clinical support staff for each clinician so that they can do the scribing and the panel management and the inbox management. It also means that our compensation systems need to recognize the role of team-based care. And we saw several really interesting examples of that in our site visits. For example, at Clinica Family Health Services, they've tried a system of pay-for-performance measures where when the quality metrics go up, it's not just the clinician, but the whole team that gets a bonus. And that sends a pretty powerful message that that change is not just coming from the clinician, but coming from the entire team. Newport News has really tried to recognize the new roles that their nursing staff is taking on by reflecting that in their pay scale. And going back for just a moment, the stories that we tell also have to change. We'll still be telling stories about innovative clinicians, but we should also start hearing stories about other members of the team who are recognizing opportunities and taking initiative. And this really came home to me at Sebastopol when someone said, you know, the metric that we have always struggled on with patient-centered care is wait times. And it was our front desk manager who had experience in the restaurant industry who said, why don't we give the patients pagers so they can walk outside to their car, they can take a walk around the block, or they can go across the street for a cup of coffee. That's the kind of story that really tells me that this is a place that practices team-based care. We believe that joy in practice actually makes team-based, patient-centered care possible. Going back to the group health experience, in about 2006, they conducted a medical home pilot at their Factoria clinic. And the first thing that they did was to try to make life more reasonable for physicians. And they did that by reducing the panel size from about 2,400 to about 1,800 and increasing the visit length. Now, we saw different strategies for trying to make life more reasonable for physicians, and decreasing the panel size was one, really building up the capacity of the team to take on care was another. They also thought about other reforms like building their teams, increasing access and continuity, implementing population-based management. And as they saw their burnout start to drop, some of these other things that they'd been working toward were a lot more accessible. They were able to increase patient access. They were able to drive down their costs, particularly their emergency department use. Their patient satisfaction increased. So conceptually, the concept of joy in practice is very closely tied to patient-centered medical homes. And as we think about driving toward patient-centered medical homes, we have to consider joy in practice. The other argument we'd make is that a lot of the innovations that we've talked about today are connected with principles of the patient-centered medical home. Everyone in this room is really working to transform primary care, and besides joy in practice, we're thinking a lot about things like access and continuity, about population management, about planning care and coordinating care. We think that those goals align very closely with the kind of innovations that we've described today and that we've seen in these practices. So for example, we've talked about things such as pre-visit planning and pre-appointment labs. We talked about sharing care among the teams and implementing things like standing orders to enable other team members to take on the care. We talked a lot about in-visit scribing and inbox management. And we talked about techniques to really improve teamwork through closer communication. We think that those kind of innovations map very closely onto these PCMH standards. So things like scribing and like inbox management can help increase capacity and improve access. These pre-visit planning and pre-appointment labs are a very important tool to planning and managing care, and the list goes on. And in conclusion, I would just say that at the core of both joy and practice in patient-centered care is the idea of teams. They're teams that are very carefully designed, they're well-designed, they're well-trained. They are teams that communicate on a minute-to-minute basis and that make time to actually sit down together and talk about their quality numbers and how to improve those numbers. Joy in practice is intimately related to patient-centered care, and if we want to achieve patient-centered care and to renew primary care, we have to consider joy in practice.